We're going to do a little speaker panel now, so a Q&A. You can still ask questions at the end. You can send in questions via email if you think of any afterwards, and of course after the talks. But I thought this would be a nice little opportunity for us to ask some questions and learn a bit more about these guys. My name's Elliot. I'm Assistant Clinical Director here at the Ralph, and my background is in ECC. You'll have Nikki up soon, who's our senior ICU nurse, but I will endeavour to answer any ECC-oriented questions if they happen to come up. But you've met everyone so far. So starting out, now Heather has been roped into a scope. Good, so she's both on call and presenting this weekend, so I just saw her in scrubs. Emma M. What's your day look like? What do you do?
So in medicine, what we do, we normally start the day by assessing our patients. So as nurses, we go down to the cat ward, dog ward, ICU. We help out with the first morning treatments. We do TPRs. We just try to get an idea of how our patients have been overnight so that we can then update our clinicians. We then do a morning rounds, again with all the nurses and all the clinicians. We update each other on the inpatients, and then we work through the list of patients that we have coming in throughout the day, what the plan is going to be, what we think they might need to have procedure-wise, so we can update the hospital coordinators and try and plan the day. We then split in several roles. Someone helps with inpatients and consults, someone helps with procedures, and someone will schedule the day, so we have different roles depending on the weeks. So then, blood tests, treatments, procedures, all of that happens throughout the day. And then in the evening, we do another rounds just to recap what's happened, to update our nurses in wards and ICU on what the plan is for the evening, and then hopefully we get to go home.
Cool. Hopefully. And then what about on-call? What does that look like?
So on-call, we do I think 1 in 5 weekends, and we just get called in if a scope needs to happen, so be it a gastrointestinal thrombody, esophageal thrombody, an airway obstruction, and then we get called in for that, and that's what Heather is currently stuck with, esophageal thrombody.
Whilst you have the microphone, there was a question from one of our student veterinary nurse friends who said they are flirting with the idea of going into referral medicine in the future, feel a bit intimidated, and then considering your pathway, do you have any sage wisdom or general advice for someone thinking about going this way?
Yeah, I mean, I started to think I wanted to do internal medicine, so then I just jumped straight in and started a certificate. But I think maybe starting with some CPD, some webinars, just getting a feel of what internal medicine is, could be a good starting point. Internship, absolutely brilliant. I did an internal medicine specific one where I just did that for 6 months. But also the rotating ones are really good because then you dip your feet in different areas. And then maybe you think you like internal medicine, but then you might change your mind. So internships, be them rotating or service specifics, are great. And if not, and if you're feeling really brave and there's an open position, then just go for it because you just learn on the job, really.
Nice, thank you. I will say from our point of view, we historically have always hired nurses into specialism-specific roles, but we're not entirely sure if the future looks like that. I think there's going to be more places that are hiring referral nurse as a general position, and you would rotate through wards, ECC, theatre, surgery, and everything else. So I don't think working in referral medicine always means you're relegated to just that specialism for the entirety of your career. Good. Thank you very much. We had a question from Physio about where she got her jumpsuit, but Kim is a spectacular crafter and made them herself. So I'm sure she'd be happy to share the pattern with you if you want to shoot an email over. But the answer is, sorry, can't buy it. We'll continue the physio medicine stream, and I messaged Kim to ask the answer, but she wanted some medicine input, and it was, should we be doing coupage and postural drainage after doing airway sampling? So if you do a BAL or a tracheal wash or something of the sort, what's your usual approach to those guys?
We definitely use coupage whilst we do a BAL. So we inject, I guess, in a way, saline into their lungs, and then we do coupage just so we can try and get a juicy sample out of our patients. After that, we had a patient the other day that was really gurgly in recovery, so we did some nebulizing, so that's definitely an option. But I guess if they were really struggling, then I don't see harm in trying to get rid of that mucus. It's definitely in there, it's going to come out eventually. So I'm pretty sure some physiotherapy could help.
Cool, thank you very much. Emma H.
Me?
Curious about up and coming things that you're really excited about. So what does the future of veterinary cardiology look like, and what are you excited to get your hands on?
All things cardio, of course. I think it's quite exciting at the moment that we work quite closely with human cardiologists. So obviously human cardio is a lot more advanced than animal cardiology, quite rightly so. And we work very closely with human cardiologists that come in and do interventions with us. So at the moment we are doing stent procedures. So where we have a pulmonary stenosis, they have kind of a challenging hyperplastic underdeveloped pulmonary artery, we can now go in and put stents in, which wasn't available before. It's amazing surgery, obviously. It's really super cool. We have very limited data because we've only done it a few times, and there's some other cardio practices that are doing it. So it's in time. We'll see in time how far we can progress with this and how we can improve the lives of our patients with certain cardiac diseases. So I think it's really, really exciting to work alongside the human cardiologists and take their take on things.
Thank you. And then any striking, memorable cases from the year? What's your most memorable case so far this year?
Oh God, there's so many. Stents, we've done a few stents this year. I think it's the cardiac interventions, to be fair. When we get these little cases, these puppies, PDAs, so patent ductus arteriosus, congenital defect. And quite often in cardio it's quite sad because it's kind of palliative treatment. So we can do our best, but we always have to go out and give some sad news. Long-term stuff is always quite challenging. But for certain congenital conditions like patent ductus arteriosus, we can go in, we can put a device in, and it's curative. So that's beautiful. And then these puppies can go on and live an amazing, happy life and never have to come back and see us again. So I think any kind of congenital defect that we can correct is amazing. Yeah.
Thank you. Question for Jess.
Hello.
So Jess, you have the luxury of only doing patient safety, quality improvement, and not having any other responsibilities at work. If that weren't the case, and you were trying to divide your time between doing clinical work and the work you do now, what do you think would be some of the highest value things that you could implement or audit or evaluate?
I would say definitely checklists. So not using checklists in practice, then we should be advocating and trying to use checklists in practice. We have not just the standard ones that we have for pre-procedure, pre-incision, and then post-procedure. We also have specific ones for things like endoscopy, for ophthalmology. So we have checklists, and they are best if they're kept short and sweet and concise, but keep the key critical safety information. So we can roll that out regardless of whether we're working clinically or not. We can have those in place. That'd be my main thing we can all do quite quickly and easily. Although when they rolled out checklists originally back in the 1990s, it was quite difficult to get these surgeons to adopt them. It's like, I'm a surgeon, I've been working for years. Yeah, I know how to do my job. I'm an expert. But it's like actually the more you've done something, actually the more chance there is to make an error or to forget something. So if you go at the thousands of times you do a procedure, it's the risk of error increases every time. So implementing checklists is something we can all do, and the medication stuff I talked about earlier as well. Trying to encourage and have advocates and have champions in your practice for certain elements of patient safety that you have a particular passion for.
Thank you very much. Becky. On the topic of what we were talking about earlier about getting into referral medicine, what was it like you making the jump from a long history in first opinion practice in busier hospitals into a big referral hospital?
I think I was really lucky because I started my student training in a small GP practice, and then I moved into 2 practices that were both referrals and GP at the same time. So we had certain halves of them that would be referrals level and GP, so we just worked to really good standards. And then I was at a very large, busy GP practice before. You just have to, I think it's more about the mentality and how much you want to learn and how well you want to do for your patients that carries you through, and then it doesn't really matter whether or not you're from GP or referrals, it's just whether or not you want to keep learning and developing, and that can be done in GP as well. But if you want to then sort of explore into specialisms, and particularly if you want to go into specific services, I would say that's probably only possible to reach those sorts of goals going into referrals practice. But it is just be brave and believe in yourself, and we all have the same qualification, we all have the same ability to do whatever we want to do in practice. So it's just if you want to sort of have a look around and see, we're very happy to do days like this so you get a bit more of an insight, and if not, and if it is too overwhelming, then a lot of referrals places do internships like we do as well, which is a nice stepping stone with a bit of extra support.
Thank you. Another submitted question, which I'm going to attempt to answer. It's actually for our Humans Not Resources department, which we call H&R. And it was about what sort of accommodations do we have in place or put in place for any of our nurses who have any degree of neurodivergence. And please feel free to jump in as well. We're very tech-based at the Ralph. We don't have paper treatment sheets, so we have laptops and screens all over the place. We are able to do screen color adjustments, or like transparent overlays or translucent overlays of different colors. The only bit of paper we do keep in the hospital is our sedation and anesthesia forms, which again we do in sort of a lilac pink color, just because it can help improve focus if you're trying to do a very focus heavy task for a long period of time. We have the luxury of having Katie, who is a veterinary nurse but now is also a licensed psychotherapist, so our accommodation for neurodivergence is a renewed focus of ours. So I suppose this is a watch this space. Maybe we'll have some more information for you in the future. Anything else you think of? Adjusted start times, anything?
Normally, if we have any sort of members of staff with any neurodivergence, what we like to do is we like to be as open and have as open a conversation as possible right from the start, and then see what we can do to support them. We have our senior nurses who are the first port of call for you in terms of sort of working out shift times and shift patterns. We often, if people need, will give them sort of a specific champion or someone they can go to as a mentor for support. Anything that needs to be done in terms of adapting sort of seating arrangements and having regular rest breaks, and we can sort of accommodate that too. And if there's any specific equipment, we quite often have people that need to wear loops throughout the day, and we're very open with that. And if anyone has any questions, then I hope that they feel that they can come to management and just see whether or not we can do anything else for them.
I should have just given you the microphone. We had a question about how do you muscle score a patient? Maybe an Emma M question? Is there a visual aid? Is there a score? Is there...
You can have we have laminates. They have pictures similarly to body condition scoring, and it instructs you as to where to feel to best get an idea of muscle scoring. But yeah, a chart, a diagram, it's got pictures on there. It's probably the easiest way to do it.
Thank you. What do you do with that information?
We just keep it on their records. It's just nice to have a baseline. So then if your patient's improving, you muscle score them the next appointment, maybe 2-3 months down the line, you can see which way it's going. It's quite useful, same as a body condition score, especially for particularly skinny friends.
Thank you. And then Emma H, maybe to wrap things up, would you just speak a tiny bit more about the VTS and what is it?
Yes, VTS is a certificate that can be offered, I think, in all disciplines. I don't know if you've ever looked. Obviously, I've got mine in the veterinary technician specialist in cardiology. You lose a year of your life doing it. I'm not going to lie. It was a personal goal of mine. It's challenging, absolutely, but I think it's so worthwhile if you're really passionate in an area and you're with a really good team. It advances your knowledge, even if you don't complete it, because it can be quite challenging. Just the actual process itself. You get involved in cases, there's all the skills lists that you have to do, you have to sit an exam at the end, like a 4-hour exam at the end as well. As I said, it's offered in all disciplines, so it's all specialised in all different disciplines. You don't necessarily have to be in referral to do it, as long as you have the caseload. There's a massive big website, depending on what discipline you're involved with. Mine is ACFIM, so all the different sites, look into it, it tells you what you need. And I just think it challenges you. I mean, I'm an older nurse now, and I love cardio. There's not much to study in cardio, and I just wanted to keep pushing myself forward. There's so much to learn. The veterinary nursing industry changes, and it's getting better and better and better. And I think it just propels nurses that can look, we're nurses, we're highly qualified, and we can do this. And this is why I did it. And so I think if anyone's interested, go for it. It is challenging, I hit my head against a brick wall several times trying to do it. There was tears, there was dramas, but I would definitely recommend it, absolutely.